A very good morning to one and all. First of all, let me thank JeevaRaksha for giving me an opportunity to talk on one of the most important aspects with respect to the airway, that is the basic airway management in adults and pediatrics. The objectives of this class would be to know the simple anatomy with respect to the upper airway in pediatric patients and adult patients, prioritize the need for oxygenation and ventilation in critically ill patients, use some of the basic airway adjuncts and equipments, and some of the techniques we are going to learn in this class with respect to the airway in adults and pediatric patients, and what are some of the alterations and implications when you are handling the COVID-19 patients. So when it comes to the initial airway assessment, the basic thing is you have to be very quick in assessing the airway. It can be done in first 30 seconds as soon as you receive the patient. A simple interventions can be initiated in less than 1 minute when you know that patient has respiratory distress. So before going into the assessment, the three important questions which you are going to ask with respect to the airway is the patient conscious? The second question is the patient's airway obstructed? Third question is the cervical spine stable? So when it comes to assessing the airway in the first 30 seconds, the important thing what you can do bedside is something called as the AVPU score. What is this AVPU score? It's a worldwide recognized scoring system which not only recognizes the defect with respect to the central nervous system, it also helps in your airway assessment. So how does it help you in the airway assessment? A stands for alert, V is verbal, P is pain, and U is unresponsiveness. So when the patient is alert and talking to you, what do you infer? Obviously, when the patient is talking, the airway is patent. So only if the patient is in distress, you try to supplement these patients with oxygen. When the patient responds to your verbal command, that means again the airway is patent, but you will have to administer oxygen and monitor such patients if they deteriorate. When the patient is responding only to your painful stimulus, then it is a threatened airway. Then there is risk of aspiration and obstruction. So such patients would require some form of assistance in the form of oropharyngeal airway and a nasopharyngeal airway. And if they still hypoventilate, you will have to assist the breathing with bag mask ventilation, and you have to consider intubation and mechanical ventilation. When the patient is not responding to any of your painful or a noxious stimulus, that means the patient's airway is threatened. You need to quickly intervene in such patients. You will have to quickly bag mask these patients and go ahead with intubation. So as you are assessing the airway, the simple techniques you can use to know whether the airway is obstructed or no is if the patient is having some gurgling sounds, that means there is some liquid material in the mouth. So it means a secretion or blood. So the intervention which you can do bedside would be something like oral or a nasal suction. If the patient has stridor, it will indirectly tell you that there are some soft tissue which is obstructing the airway. In such circumstances, what you can do is a simple airway maneuver like a jaw thrust and the chin lift maneuver can relieve the obstruction, or also you can use airway adjuncts like oropharyngeal airway or a nasopharyngeal airway and make sure there is relief from the airway obstruction. But before you do this, the next question which comes to your mind is the cervical spine stable? In a trauma patient, there is a general rule of thumb which says that all trauma patients are suspected cervical spine injury patients. So avoid any form of airway maneuvers and make sure they are stabilized with respect to the airway. Give a 3-point stabilization before you start ahead with assessing the airway. Coming to the anatomical aspects with respect to the pediatric airway and the adult airway. In the pediatric airway, the thing you will have to know is the tongue is larger compared to the adult airway. So it occupies a majority larger portion of the area in the oral cavity. The epiglottis is floppier, U-shaped in child, and it is shorter in adults. The vocal cords are upward slant in child and horizontal in adults. In the pediatric airway, the narrowest portion is the cricoid. Trachea is obviously narrow and less rigid, and obviously the lung capacity of the pediatrics are less compared to adults. So these are some of the basic airway differences you will have to know with respect to pediatric and adult. So next in the airway anatomy is the laryngeal inlet you will have to know. So from the base of the tongue, what comes is the epiglottis. So this is the epiglottis, what usually omega shape in pediatric patients. This is the epiglottis in adult patients. As you go below the epiglottis, you can see white shining structures. These are the vocal cords, the true vocal cords, the left and the right vocal cords. And these are the laryngeal cartilages in the posterior aspect. So this is how a laryngeal inlet looks while you are intubating. This is the left side is a pediatric patient and right side is the adult patient. Coming to the priorities of resuscitation with respect to the airway, you have two important things with regards to resuscitation in airway. One is oxygenation and other is ventilation. Oxygenation just means you're providing oxygen to the airway so that the oxygen from the lungs enter the bloodstream and hence into the tissue. Ventilation not only involves the oxygenation, it also involves moving out of the expired gases, especially the carbon dioxide, from the tissue level to the lungs and out to the atmosphere. So establishing an open airway between the outside world and the lung is important. The oxygen has to go in and the CO2 has to come out. If this is not accomplished, this will lead to the death of the patient. Next is the oxygen administration. Oxygen is good for hypoxic patients. You have to correct the hypoxia irrespective of the underlying condition. As in the cardiovascular system, we always tell as you're resuscitating the patient, you will have to optimize the cardiovascular system. The same with respect to the airway. Oxygen must be delivered at the same time when you're assessing the airway. So oxygen in the room here has 21%. So sometimes this might be not sufficient. So you will have to give some artificial mode of oxygen to the patient to increase his oxygen requirement as his demand is more. What are the causes for hypoxia? It can be a simple airway obstruction, inability to breathe, or a cardiopulmonary dysfunction. So this has to be done quickly within the first 30 seconds when you're assessing the airway. So when you're delivering oxygen, there are some things which you will have to know with respect to the delivery methods. So you have decided now to give oxygen. So the next would be how are you going to give this oxygen? You can give oxygen with a simple nasal cannula, a simple nasal face mask with reservoir and a bag mask ventilation. When it comes to the first device, the simple nasal cannula, it is also called as a nasal prongs. The maximum oxygen which can be delivered with this would be 1 to 4 liters. The 4 liters is the maximum oxygen. If you go beyond that, what happens is there is a drying of the mucosa and patient become non-compliant with nasal cannula. The maximum FiO2 you can reach with the nasal cannula is 40%. Next is the simple face mask. In this simple face mask, the oxygen you can start with minimum of 4 liters and go to maximum of 10 liters per minute. Beyond that, the oxygen gets wasted and it's not being used by the patient. So the maximum FiO2 you can reach with a simple face mask is somewhere around 60%. The next oxygen delivery device would be a face mask with reservoir. You can go up more than 10 liters because it has a reservoir bag and go up to 15 liters. The important thing is the reservoir bags acts like a reservoir for oxygen. So if the patient's demand increases, he will not be taking in air from the atmosphere. Instead, he will be taking the concentrated oxygen air present in the reservoir bag. So this is the advantage of the reservoir bag compared to the simple face mask. The maximum FiO2 you can reach with this would be somewhere around 80%. And next is the bag mask ventilation, which is also called as a AMBU bag, which we say. Here you can give oxygen more than 100%. This is mainly used during resuscitative procedures, during pre-oxygenation, where you can go up to 15 liters. You can connect a reservoir bag to increase the FiO2 achieved. The maximum FiO2 you can reach would be somewhere around 90 to 100%. But coming to all these devices, the important thing you will have to keep in mind is the first three devices which I spoke can be used only in patients who are conscious and who are cooperating for the treatment and who are not much in respiratory distress. If the patient's respiratory distress worsens, then you will have to go with the advanced form of airway devices. So patient compliance and patient's respiratory efforts is a must when you're using these basic oxygen delivery devices. So when you're giving oxygen to the patient, you have to have some form of monitoring. So this is called as a pulse oximetry, the fifth vital sign. So what is the advantage of it? It measures the blood oxygenation, and the most disadvantage what we see in a day-to-day practice is it cannot be used in patient with cold clammy peripheries, hypotensive patient is moving a lot, patient's finger is amputated, or sometimes the whole hand is not available for you to measure, or the patient who is hypotensive. So these are some of the demerits of using this pulse oximetry, but very handy device. It can be used by even a common man, and it helps us to identify any form of hypoxia. The other disadvantage of it cannot be used to measure the CO2, so it won't tell us how is the ventilation of this patient. So the normal values are 90 to 100% in normal adults, and less than 90% is termed as hypoxia. So whenever you are assessing a patient with respect to the airway, the position of the patient is very important. So when you're giving the position of the patient, it's always better to have a patient in the sniffing the morning air position, where there's extension at the neck and extension also at the Atlanta Hospital junction. So how you can do this is placing a towel under the shoulder of the patient. So why do you do the sniffing in morning air position? So this position is useful because when the patient is in normal neutral position in supine, there are three axes like the oropharyngeal axis, parapharyngeal axis and the laryngeal axis. All these three axes are in different plane. So when you do the extension, all these three axes come in a single plane, and if by chance you're planning to intubate that patient and put a laryngoscope, you can see directly the vocal cords with simple techniques. So you are giving this extension position so that all these three planes come in a single plane and you can easily visualize the vocal cords. So once the position of the patient is placed, you will have to see if there is any form of obstruction, which we already described, and you will have to do suctioning if there is any secretions. You will have to start supplementing oxygen in patient when you are examining the patient. If there is some form of hypoxia, sometimes you will have to use some airway adjuncts, and if that is not working, you will have to go with advanced airway adjuncts. Coming to the airway management techniques. So once you know that patient is in respiratory distress, you will start some basic bedside airway maneuvers like the chin lift and the jaw thrust. If there is some form of obstruction, then you can use airway adjuncts like the oral and nasal airway. These can be done bedside with simple techniques and simple practices. And next would be, if this is not relieving, you will have to think about bag mask ventilation, and once you know that is a threatened airway, you will have to go with advanced devices like supraglottic airway devices, endotracheal intubation and cricothyrotomy. So in this class we will be talking about only the first three because these are classified as the basic airway management techniques. So coming to the airway management, how do you open the airway? The simplest maneuver what you can do bedside to open up an airway is head tilt, chin lift and jaw thrust maneuver. So by this I told you the three axes come in line and the airway is open. The anterior muscles of the neck can be extended and it gets taut so that they don't fall to the posterior aspect of the airway and block the airway. So this head tilt and chin lift is done in almost all the patients, but there are a few contraindications where you have to know. As I told you, in a trauma patients, always we suspect a cervical injury. In such patients, it is contraindicated because this maneuver can compress the spinal cord and it can worsen the patient's neurological status. So any patient with history of neck surgery or cervical spine pathology, you don't go ahead with this maneuver. In such patients, you do only thing called as a jaw thrust maneuver. So coming to the airway maneuvers, how to open the airway. The first technique is what I told you. You're going to do a head tilt and chin lift. So by this I told you the anterior airway muscles are they're stretched and they come away from the posterior aspect, and the airway is patent, and there is not much pressure on the trachea. So this can be done in almost all of the patients, but any patient with cervical trauma, along with the 3-point stabilization, to open up the airway, what we do is something called as jaw thrust maneuver. In the jaw thrust maneuver, you just try to protrude the jaw. Once you protrude the jaw, the tongue which is attached to the jaw, it gets pulled forward, and hence the obstruction is relieved. So when it comes to examining a pediatric patients, so we all know that pediatrics have a larger head compared to the body when you compare it to the adults. So because of the larger head, what happens is the neck is flexed forward and it causes an obstruction to the airway. So how do you relieve this obstruction in pediatric patient? I told you, just like an adult patient, what you can do, or you have to do in almost all the pediatric patient, is placing a pillow or a cotton roll just below the shoulder blades so that the head is extended and the airway obstruction is relieved. So when it comes to a total unconscious patient, the most common cause for airway obstruction is the fall of tongue. The tongue falls to the posterior aspect of the airway and it blocks the normal conduit of air. So relieving that obstruction, especially the tongue obstruction, becomes the important part regarding the basic airway management. So when you know that tongue is the main culprit for the airway obstruction in the patient, you can do a simple technique which I explained to you previously, is the extending the neck and protruding the jaw. So once you do that and the airway obstruction is relieved, then indirectly tells you the tongue is the major culprit. So you can't keep doing this maneuver for a longer time. So that's why you will have to use some airway adjunct so that your hands are free for examining the patient and resuscitating. The first airway adjunct we are going to discuss would be the nasopharyngeal airway. It is available in many sizes, can be used both in adults and pediatric patients. So how do you measure the airway adjunct? So airway adjunct is measured both in adults and pediatric from the angle of the nose to the tragus. So that would be the optimal size of the nasopharyngeal airway. And how do you insert it? You are going to put a lubricating jelly around the nasopharyngeal airway, and you're going to push it perpendicular to the face so that it goes in from the nose and it goes to the oropharynx. Once it goes to the oropharynx, the tongue is pushed anteriorly so that the tongue obstruction is relieved and there is a good conduit of passage of air. The other adjunct which you can use is oropharyngeal airway. As in nasopharyngeal airway, this oropharyngeal airway should be used only in unconscious patient because this can cause a gag reflex if used in a conscious patient, and the patient can vomit and aspirate. Nasopharyngeal airway can be used both in conscious and unconscious patient. Just like nasopharyngeal airway, you have multiple size both for adults and pediatric. How do you measure this oropharyngeal airway? You're going to measure it from the midpoint of the incisor to the angle of the mouth. So this would be the right optimal size for pediatric. Also for adults, it would be the same technique, but insertion technique is quite different from the nasopharyngeal airway. In the oropharyngeal airway, you will make sure the curved face is facing upwards. As you push in, you get resistance that is somewhere between the soft palate and the hard palate. So at that junction you get a resistance. Once you get the resistance, you're going to turn it 180 degrees and then push it. So here you don't require any jelly because the oral cavity is already moist and has some amount of mucus, so that placing this would become easier. Once you push in, the tongue is pulled forward just like the previous airway, and it relieves the obstruction. So mind you, the only difference is you have to use this in unconscious patient, and because conscious patients, they will be gagging and aspiration. So once you have relieved the obstruction and you have placed appropriate oxygen delivery device, sometimes this won't be sufficient. Patient will be still hypoventilating or having hypoxia. In such a thing, what you will have to do is a bag mask ventilation. This is a very important thing and requires some amount of expertise. So what you will basically do is you try to use one hand to maintain a seal around the face, and so that you give all the oxygen provided is going to the patient. With the other hand, you try to bag mask the patient. So this is you will utilize both your hands to form a facial seal, then also to give a proper positioning of the patient, and the other hand will be used to ventilate the patient. So when you're selecting the proper size of mask for a bag mask, you should make sure the narrowest portion of the mask sits on the nasal bridge of the patient, and the widest region of the mask sits on the mentum. So this will indirectly tell you this is the right size of the mask, and whenever you're back masking, there won't be much leak if you're selected the right size of the mask. So when you're doing a bag mask ventilation, what is this technique called? This is called as a C and E technique, and this C and E technique can be done with patient with oral adjunct and without oral adjunct also. So how do you position the patient? Would be the same, sniffing the morning air position. So with the hand you're going to hold the mask, you can do the C and E technique. What is the C and E technique? The C is from the thumb and the index finger. It ensures there is a tight seal to prevent the air leak, and it presses over the face. The E technique, you can see in the next diagram, your other three fingers from the E. One is at the mentum, other as the middle of the mandible, the last one at the angle of the mandible. So make sure all these three fingers are on the bony prominence. This will help to lift the mandible and extend the neck and maintain the airway. So this is how you're going to hold the face mask when you're doing a bag mask ventilation. So when you are doing a bag mask ventilation, there are two techniques which can be used. One is the 1% technique and the 2% technique. In 1% technique, as the name suggests, there will be a single rescuer. The same person will hold the mask and bag mask the patient. In a 2% technique, mainly used in obese patients or sometimes patient with a large face, or patient where you can't patient's rescuers hands are very small. In that time you can do the 2% technique, where what is this 2% technique is, in both the hands you're going to do the C and E technique. The C to form the tight seal, and the E of both the fingers will be placed on the mandible and maintaining the airway. The second rescuer will try to bag mask as per the rates which I'm going to discuss in the next slide. So this is called as a 2% technique, and you can use either the 1% technique or the 2% technique. So when you're doing a bag mask ventilation, it's always advised to assess the efficacy of your bag mask ventilation. So how do you assess the efficacy of your bag mask ventilation? A simple technique what you can follow bedside is look for any chest rise of the patient. If there is no adequate chest rise, then there is some amount of leak and you will have to reposition or change your technique. And if you have a stethoscope, just try to auscultate if there is bilateral equal air entry. Feel for the compliance of the bag. So the compliance of the bag indirectly tells you if there is any pathology in the lung. Example, if there is a pneumothorax, your bag masking becomes very hard. So it indirectly tells you the underlying pathology. And whenever you're doing, look for some dynamic parameters like SpO2 monitoring. Have a SpO2 probe and see for oxygenation. So what are the normal rates of ventilation? In adults, it is recommended somewhere around 10 breaths per minute. In children, it is 20 breaths per minute. Infants, it is 30 breaths per minute, and in neonate, it's 40 breaths per minute. So this is a general rule of thumb where you will have to know the frequency of bag masking the patient. So when you're doing a bag masking, the most important thing you will find is difficulty in bag masking. So when you find this difficulty, it is not anything very serious. It's a simple thing what you can do. Your technique is not proper. So when your technique is not proper, always try to optimize the patient's airway. Make sure the patient is having a sniffing in morning air position. If by chance you're not placed an airway, you can place an airway so the tongue obstruction is relieved and your bag masking becomes easier. See if there is any secretions and suck it out so that the airway is clear. If you're doing a single hand technique, use a two hand technique. Call for help, use a second rescuer and ask them to bag, and use both your hands to form a tight seal around the face. Remove the pillow and open the airway. So opening up the airway with just opening up the mouth can be one of the technique what you can do in bag masking the patient. So in spite of this, sometimes you can anticipate or you can get a difficult bag mask ventilation, especially in patients with hairy face and deformity where holding the mask becomes very difficult. Obese patient, again it's very difficult. Patient is having any form of a tumor, again can obstruct the passage of air. Younger patients and elderly patients, again because of their edentless nature, you can have a lot of air leak. And a patient who are having a stiff neck and or you are not able to bag mask such patients. So these are some of the common difficulties what you can face when you're doing a bag mask ventilation. In the pediatric patients, apart from the previous thing, in general it is difficult to bag mask patient because the head is big, so it needs to be supported, and I told you the technique how to support it. You can straighten the patient's airway by placing a roll or a cotton roll or a pillow just below the shoulder so that the head is neck extended, so the airway is patent. Use a smaller size mask to fit properly. The mask size should be between the bridge of the nose to the chin. So important thing in pediatric is if you have an oversized mask, not only can it lead to the leakage of the gases, but also it can cause damage the eye, and some of the air jet can cause vagal responses and cause hypotension and bradycardia. Use small tidal volumes and increase the frequency of breaths. So these are some of the precautions what you will have to take with respect to bag mask ventilation in pediatric patients. So, so what are your targets? So whenever you are bag masking or giving some form of oxygen, you should have a target with respect to the resuscitating procedure in the airway. When it comes to SpO2, you have a target of more than 90% in non-pregnant adults, and in pregnant adults you need a higher saturation somewhere around 92 to 96%. When it comes to pediatric patients, your target would be more than 94%. So when you're resuscitating any of the patients with respect to the airway, not only do you need airway adjuncts and oxygen delivery devices, you will have to have some good form of monitoring devices, especially a pulse oximetry, and you will have to keep ready for crash intubation. So you will have to have a crash cart along with the advanced devices. So this is how the pulse oximetry looks like, where you can place it over the index finger and you can measure the saturation of the patient. So these are the basic airway adjuncts and their techniques with respect to any hypoxemic patients. So when it comes to COVID-19 specific patients with the type 1 respiratory failure, how are you going to manage it? So the dictum remains the same. Airway breathing circulation becomes your priority. As we're talking about airway, so I'm going to talk a little bit in depth with respect to the airway optimization. So in patients with type 1 respiratory failure, especially COVID-19 patients, you will have to initiate with oxygen delivery devices, preferably a face mask with reservoir. So because most of the patients are tachypneic and their oxygen requirement is high, you will have to start with the oxygen reservoir bag instead of a nasal cannula or a face mask. If the oxygen requirement comes down, then slowly you can come down on your delivery devices. You can go to a face mask or a nasal cannula. But important thing is recognize severe hypoxemic respiratory failure when a patient respiratory distress is failing the standard oxygen therapy. So you will have to quickly upgrade to a higher oxygen delivery device like a NIV or HFNC, or sometimes even this won't be sufficient. You will have to go ahead with intubation and mechanical ventilation. So when it comes to HFNC and NIV, the important thing is what is this NIV? NIV is you're going to form a tight seal around the nose and the oral cavity, and the gas is given in a pressurized form. So this form of delivery will give some form of support to the respiratory system, so and it helps in increasing the oxygen in the blood. So this is usually useful in patient with respiratory distress with some form of hypoxia. The other form would be your high flow nasal cannula, which is used only for oxygenation. So both these devices can be used for a non-invasive purpose. Before you can, if the patient worsens, you can go ahead with mechanical ventilation. In the pediatric patients, this NIV cannot be initiated because this requires some form of cooperation from the patient. So in pediatric patients, we prefer mainly the bubble CPAP, which is also a type of high flow nasal cannula, which helps in oxygenation of the patient, and it gives some amount of PEEP also. So this is a non-invasive technique where it is helpful in type 1 respiratory failure. So what is this high flow nasal cannula? I told you this high flow nasal cannula, it helps actually, the oxygen is given in a high flow, as the terminology say, it is given in a continuous high flow. So because the oxygen is the air is enriched with oxygen and it's given in a high flow, most of the upper airway, which acts like a dead space, what we say the anatypical dead space, it is replaced by oxygen. Usually it has oxygen and carbon dioxide, but because of the high flow which is generated, this is completely replaced by oxygen. So this will act like a natural reservoir to the patient. So because it acts as a natural reservoir, when the patient is tachypneic, when he draws in air, this is oxygen enriched air goes to the lung and it helps in treating his hypoxemia. Because the flow is high, it generates some form of PEEP. So as you all know, PEEP helps in oxygenation. So this is how the basic mechanism of high flow nasal cannula acts. It avoids the rebreathing of CO2 and therefore decreases the anatomical dead space. So what you will have to know is, when you're doing this high flow oxygen supply to the patient, you will have to keep ready the crash cart, as I told, because the high flow nasal cannula or NIV is you give it to a patient who is going to be in respiratory distress at the initial time. So you're going to give a trial of these devices. If it is not working, so if it's not working in about 1 or 2 hours, you don't overtry this. You will quickly have to get ready and intubate this patient. So you will have to be very vigilant in such patients, and you will have to have experts around you when you are handling such patients. So once you're using a non-invasive form of ventilation, the important thing what you can think about in a hypoxemic patient is something called as self-proning. So this awake self-proning can be done by the patient who are conscious, who are cooperating. So this is an important aspect of increasing your PEEP and indirectly helping your oxygenation. So the patient has to be conscious and very cooperating for this procedure. So it can be done in any form of oxygen delivery devices like a nasal cannula up to the NIV or high flow oxygen cannula. What you do is you make the patient to sleep on the belly for 30 minutes. You initially start with 30 minutes and you can go up to 2 hours. Then you can go to the either the right and the left lateral position. That also includes for 30 minutes to 2 hours. Once they finish both the right and the left lateral position, they again go back to the sitting position of 30 degrees, where they again stay there for 30 minutes to 2 hours, and they repeat this procedure. So this is called as awake proning, which is very helpful for patients who are hypoxemic, and avoids intubation in most of the cases. And the important thing is what are the contraindications for awake self-proning. I told you patient has to be cooperative. If the patient are not cooperative or delirious because of hypoxia or severely respiratory distress, tachypnic, they can't do this procedure. So don't do this procedure in such patients. Directly you have to intubate, and then you can think about proning the patients. Patients with again cervical injuries or patient with any spinal deformities, you can't do this position. So when you're doing a back mask ventilation, we already discussed about the back mask ventilation. When you're dealing a COVID patient, so how is it different with respect to the back mask ventilation? This back mask ventilation, I told you, it helps you in pre-oxygenation in normal patients. But in COVID patients, try to avoid back mask ventilation during pre-oxygenation. Instead, switch on to 100% non-rebreathable mask for pre-oxygenation. Manual bag mask ventilation should be minimized as much as possible. You can cut down the duration of bag mask ventilation. This is because the bag mask ventilation can generate a lot of aerosols and it can contaminate the surroundings and you can get infected. So this is the reason why we do decrease the duration for bag mask ventilation. But if you are doing a bag mask ventilation, how do you safeguard yourself and your healthcare workers is by placing a hydrophobic filter between the face mask and the breathing circuit, or the what we say this the bag mask ventilation. So if you keep a bacterial filter, the aerosol droplets gets adhered to these filters and it decreases the aerosolization. And when you're doing a bag mask ventilation, preferably it's better in a COVID patient do a 2% technique, because both the hands of a first rescuer will be used to form a tight seal. So again the aerosolization generation will be reduced, and the risk of contamination is again reduced. So always use a 2% technique. So these are some of the changes with respect to the COVID-19 patients. This is a two rescuer technique, a two hand technique which we already described. So these are some of the basic airway adjuncts and also some of the improvisation what you will have to do in COVID-19 patients. So the next aspect with respect to the airway is infection prevention control protocols. So the standard infection control protocols will be applied also in COVID patients, like using PPE will be one of the important aspect with respect to the infection control protocol. Always have a good hand hygiene technique, because that is a commonest source for contamination of infection and movement of infection from one patient to other. Standard precautions also include patient placement. They have to be placed in an appropriate area and not mixed with non-COVID patients. The simple technique like hand hygiene, and along with discarding the waste, because that is also one of the source of infection for most of the healthcare workers. So the standard basic infection prevention control protocols also have been included in the COVID-19 patients. So when you receive the patient in trials, what are the things you can do to prevent the infection? Give a suspect always a AAA or surgical mask as soon as he reaches your trials. Try to maintain a distance whenever you're examining the patient. At least a 1 meter difference is advised. Try to avoid many people examining such patients, and decrease your also frequency of examining the patient. Try to finish it in one go. So try to isolate them in a particular area so that they don't get mixed with other patients. Instruct all the patients to cover nose, mouth during coughing or sneezing with the tissue or a flexed elbow for others, so that the aerosolization is decreased. And obviously you will have to perform the hand hygiene, which is the key for preventing the infection. So apply droplet precautions. So prevent the droplets are the larger particles which have higher virus load. So you will have to isolate such patients in a particular isolation ward. Always try to group these patients in a particular ward so that they are isolated. You have a dedicated nursing staff and doctors looking after them in a shift basis so that not multiple people are exposed. Also try to limit the movement of patients from one area to other. So always try to have all the investigations and any of the procedures done in the same area. So isolating these patients in a particular dedicated area will prevent your spread of infection. The next with respect to the infection control would be contact precautions. So contact precautions would be using PPE whenever you're examining the patient. Use disposable and dedicated equipments if you're able to, your hospital is able to afford. If not, make sure these instruments are disinfected between each patient's. If you're also whenever you are examining such patients, it's very important that the healthcare worker also is following the hand hygiene techniques, and he also refrains from touching his eyes and nose and mouth, because this is one of the most important thing also explained in literature, how healthcare workers are getting infected because of their because they're not for following the hand hygiene, or if they're using the contaminated gloves and touching their eyes and mouth, which is the commonest source of entry of infection. Also, the environment surface has to be cleaned and disinfected regularly. These are simple precautions which has to be done with respect to contact precautions. Next is the airborne precautions when you're doing aerosol generation procedure. So important thing is when you're doing a suctioning procedure, always use a closed suction. Avoid using an open suction because it can not only infect the other patients, also it can infect the healthcare worker. When you're doing other resuscitative procedure, make sure you're doing it rightly with the right technique and using a PPE. Adequately ventilated room is an important thing, because you will have to have a negative pressure room to remove all the droplets which is generated in the isolated room. Or if you don't have a negative pressure room, at least make sure the room has good ventilation, and so that you open up all the doors so that all the respiratory droplets are moved out and it's not present in the closed room. Avoid unnecessary presence of individuals in the room. Try to always keep the patient in the same room, because most of the places where we have seen it, the patients have or category A and category B are separate. So if the patient crashes, try to avoid the movement of the patients. Try to have ventilators present in the same area so that you don't require to move such patients. Your radiological investigations also can be done in the same room to avoid moving that patient. So these are some of the important prevention strategies what you can keep in mind to prevent the airborne. Next would be the infection control precautions when you're using an HFNC and NIV. These are considered to be highly aerosol generating procedures. So apart from the standard precautions what you undertake for airborne precautions, there are some alterations which with respect to the NIV and HFNC you will be doing. When you're using an NIV, make sure you're using a tightly fitting mask. This will avoid air leaks and aerosol generation. When using a high flow nasal cannula, make sure you titrate the flow rates to the lowest possible to maintain a saturation more than 90%, because I told you the high flow nasal cannula has a higher flow rate to achieve this. And this higher flow rate indirectly can cause aerosol generation. So because of this, it is very important for us to make sure you target a saturation of just 90%, so that the aerosol generation is less. If you are using NIV and you have a provision of using a helmet, that will be a better option compared to a NIV mask, because this helmet will prevent the aerosol generation, and also the pressure required would be less, and the contamination is less because the infected particles get isolated within the NIV helmet. When you're using a NIV ventilator, it's better to use a double filter or a bacterial filter at the expiratory limb, because it will trap all the infectious particles and also the secretions and prevent the infection from entering into the system. So to conclude, in a nutshell, we have discussed regarding the anatomy of airway in pediatric and adult patient. What are those differences? How do we examine an airway? What are the airway adjuncts available in pediatric and airway patients? What are the basic oxygen delivery devices in adult and pediatric patients? And when it comes to COVID-19 patients, how differently we can use this? What are the implications of these devices, and what are some of the alterations we are doing with respect to the infection control procedures? And what are the basic standard infection control procedures? And we have discussed most of the aspects with respect to the basic airway assessment in adults and pediatric patients. I hope this was very clear to all of you. If there are any doubts, we can clarify this during the hands-on procedure, and I hope to see you back in the practical session. Thank you one and all for your patient listening.